It's our pleasure to welcome you all in our third lecture in Breast Ultrasound Lexicon, Interpretation and Management. Please join me in welcoming our host, Dr. Rabab Mohammed, consultant radiologist. Thank you, Dr. Rabab, for your time and effort preparing and presenting this lecture. You may start now.
Thank you, Nauras. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد وآله وصحبه أجمعين وببركته بإذن الله موفقين. Good evening all and welcome everyone and welcome Dr. Rayah, our boss, for today's session as a continuing discussion of the characterization of breast lesion based on BI-RADS lexicons. Okay, still talking about associated features. Regarding associated features in the BI-RADS lexicons, last time we talked about architectural distortion, duct changes, skin changes, and the newly added echogenic rent. Okay, today we are going to talk about edema and vascularity. However, the elastography assessment will be done later in a separate session to discuss it more. Okay. Edema. Edema, it can be focal, can be diffuse, it can be unilateral, it can be bilateral. Here we have multiple examples of aggressive lesions or highly suspicious lesions with perifocal edema presented as increased echogenicity with lack of normal tissue differentiation, fat glandular interface lost it, and the fat lobule swollen, as well as overlying skin is also edematous and thickened. Another examples here of perifocal edema. Okay, if we here we have the previous examples were breast cancer, but these again aggressive or highly suspicious lesions, however, representing a benign process in this example and this example, while this example is also breast cancer. Look how these lesions simulating each other's and associated with perifocal edema, that is make it more challenging. That's why presence of perifocal edema is a suspicious feature to be added to other morphological characteristic of the breast lesions. Again, here we can see examples of perifocal edema in a cyst. This is a 50-year-old lady presented with a palpable abnormality near to the nipple, presented as a simple cyst. In the first visit, after a few weeks, she started to develop pain, okay, over the area of palpable abnormality. Scanning of heart demonstrate some inflammation of that cyst, evident by lack of imperceptible wall. Now it developed some thickening of the wall, and there is internal debris causing debris fluid levels, okay, as well as perifocal edema. So these features representing acute suppurative cystic lesions. Here we have diffuse edema in a case of congestive cardiac failure, evident by swollen hyperechoic tissue. Look for the tissue, how it is swollen and how it is hyperechoic. Also, the network of facial planes fluid, you see, evident as hypoechoic or anechoic, linear and curvilinear lines digitating and forming a network. And generally, the bilateral diffuse breast edema is seen in systemic conditions like heart failure, renal failure, liver disease, and so forth. Okay. Here we can see example of diffuse breast edema, but it is a unilateral in this, and it is a rare presentation of unilateral breast edema in congestive cardiac failure. Generally, unilateral breast edema expected to be seen in a case of infection or post-surgical, post-radiation changes, or less likely due to tumoral, venous, or lymphatic obstruction in inflammatory breast carcinoma. However, systemic disease usually presented by bilateral breast edema, but in a case of cardiac failure, it is rare. To be honest, I have a couple of cases, but unfortunately, I couldn't find them in my collections. I have a couple of cases with unilateral breast edema in a case of congestive cardiac failure, such as in this example from the literature, okay? And it is usually related to the patient tendency lie to one side. In this case, the patient was predominantly lie on the right side, while she developed edema on her right side. It is a dependent edema, and it was resolved in 2 days after diuretic therapy, which is expected. This is another cause of unilateral edema, which is post-radiation. In post-radiation, in acute phase, there is increased vascular permeability that can result in diffuse breast edema, including secondary skin thickening. While in chronic cases or long-standing, the process is attributed to small vessel damage by radiations. Okay, that can also result in breast edema with secondary skin thickening. So it is best appreciated when compared with the contralateral side, as in this case. Here, the post-radiation obviously seen in the left side compared to the right side. Look for the tissue differentiation and echogenicity. There is diffuse increased echogenicity with lack of fat glandular interface, okay? Complete loss of differentiation, tissue differentiation, and some fluid in subcutaneous and facial planes, as well as skin thickening. And this is irregular hypoechoic area due to post-surgical scarring. The maximal edema and skin thickening expected in post-radiation during the first 6 months after completion of therapy. And then it has to be diminished, okay, or may, remain stable within the 2 to 3 years. Following 2 to 3 years, expected to be either declining or to be stable. So if there is worsening in the thickening, skin thickening, or in the breast edema after 6 months, okay, then we have to do workup, because the differential diagnosis of that, if it is not due to systemic cause like heart failure or renal problem, or due to local infection mastitis, it might signify recurrence, and it could be related to lymphatic spread or obstructed by venous drainage. So we have to investigate the patients and make sure there is no recurrence. This is my patients of acute fat necrosis presented with diffuse edema, 2 cases. And this is also my patients having lactational mastitis. Because of active lactating breast, it might be little bit looked similar, the right and left, okay? But if we concentrate and we compare it, there are some subtle features that differentiate the conditions. Apart from the clinical, the patient presented with diffuse pain and tenderness in the right breast. Here, this is the glandular breast tissue, gray, and here it is more bright and swollen. Look for this. This is the fat, and the glandular tissue also become more hyperechoic and swollen. And the ducts are non-compressible because of the edema, not compressible during scanning. While this one, the ducts here can be easily compressed. So infectious mastitis considered to be the most common pathology during lactation and pregnancy. This is also my patients here having granulomatous mastitis. These are one lesions, okay, in trans and longitudinal, and here we can see remarkable diffuse breast edema in subareolar regions, okay, skin edema, as well as complete lack of tissue differentiation and increased hyperechogenicity. Would you recommend a biopsy in such case? Yes. Why? Because there is overlap between inflammatory process and malignancy. Again, these my patients, okay? This is one patient. This is a 51-year-old lady presented with tender swollen left breast. A similar younger patients, 40-year-old, presented with left tender swollen breast, and this is the third patients. All of the three diagnosed to have granulomatous, idiopathic granulomatous mastitis, presenting with extensive diffuse edematous left breast. Okay, compare it with this, a malignant patients having more or less the same changes. So we have to proceed for biopsy to make sure is it inflammatory process or malignant process, especially if not responding to antibiotic in the first 10 days to 2 weeks. Here we have another example of inflammatory cancer presenting with diffuse edema, with diffuse increased echogenicity. Look for the swollen tissue or swollen fat lobules. Look for the fat lobules, how the size of this fat lobule, and intervening fat in a facial planes. And also, you can see here, this is irregular, suspicious hypoechoic mass with posterior shadowing deeply sighted in such case, in this case, sorry. Okay. During my experience outside Sudan, which represent most of my experiences in breast imaging, malignant edema is much less common than systemic and inflammatory etiology. Here I have another one more example of inflammatory cancer from that experience, presented with diffuse edema, as well as these are interconnecting irregular masses and non-mass-like lesions, okay? As well as diffuse breast edema with lack of tissue differentiation and some of subcutaneous and facial plane fluids and thickening of the skin. Unilateral breast swelling during inflammatory breast carcinoma is rare, according to the literature. Not only according to my practice, but also according to literature, it's only represent 1 to 6%, okay, of breast cancer, and a highly representing a highly aggressive type of breast cancer. And symptoms suggested the diagnosis is rapid onset edema with beady orange okay, without a palpable lump. And the duration of symptoms for usually for less than 6 months. And however, these are not associated with worms or erythema that present in inflammation of the breast or mastitis. However, let me present to you a different scenario. A breast cancer in Sudanese woman during my latest stay, just before the war. Practicing breast imaging in Sudan, I saw hundreds of malignant edema in less than 2 years. And here I'm going to share with you some of such cases. This is one example. This is one patient, you see, presenting with extensive edematous breast. Okay, look for the thickness of the skin and lack of differentiation and heterogeneity of the breast parenchyma due to intermixed of edematous breast with infiltrating malignant process. See, these are the non-mass masses and non-mass lesions scattered within the breast, within the edematous breast. Look how the skin, how the adjacent non-infiltrating tissue is hyperechoic edematous and hypoechoic network due to increased fluid, interstitial fluid in the facial plane and dilated subcutaneous and the dilated subcutaneous lymphatics. Okay, here we can see this pink asterisks represent the fluid, okay, either hypo or anechoic, but mostly hypoechoic because mostly is a lymphatic fluids, okay, relatively echogenic, and these representing hypoechoic masses and non-mass lesions. Another patients here, you see, can you see how look for the more than 1 centimeter, the skin thickening, and look for the breast edema again with the fluid, okay? So usually in case of malignancy, as we mentioned earlier, the malignant edema is mostly related to venous and or lymphatic obstructions, okay? One more example, okay? Edema in breast cancer in left breast, looking for the same process, intermixed patchy area of hyper and hypo due to infiltrating malignancy and adjacent swollen edematous breast and the network of fluid in the lymphatics and facial planes, okay? Result in congestion. One more case. Here we can see a mass. You see, these two cases actually, two cases. This here also look for the swollen hyperechoic, and in this example, here we can see lesions. A mass, actually a mass. It has a convex border. Diffuse increased echogenicity and the network of fluid, pronounced skin thickening and edema. Here, 4 examples, another 4 examples, variable. This area is diffuse increased echogenicity with complete lack of differentiation, and here subcutaneous lymphatic dilatations and interstitial fluid in the facial planes, okay? And here, this is the infiltrative malignant process and the surrounding edema, the surrounding edema, the hyperechoic, and the infiltrating malignancy is hypoechoic. Here we can see one example. This is a mass, okay, mass lesion and diffuse edema. And here there is some infiltrations. This is the malignant infiltrations and the remain of the surrounding hyperechoic and swollen due to underlying edema. 3 more examples, okay. Diffuse edema again. Here predominantly seen the network of the subcutaneous dilated lymphatics and facial blur due to network of facial blend due to interstitial fluid collections. Okay. 3 more example to see more cases. You see, these all are Sudanese cases I have seen only during less than 2 years, only less than 2 years, okay? And I am happy to share them with you. Again, 4 more cases. Here, this is the malignancy. And look for the diffuse edema with lack of differentiation, remarkable skin thickening. And here, these are in hypoechoic infiltrating lymphatics, subareolar lymphatics with the malignant process surrounding with this diffuse hyperechogenicity due to swollen edematous breast. Look also the skin become hyperechoic edematous with lack of the underlying differentiation between the skin and the subcutaneous tissue. All of the tissue become hyperechoic due to extensive breast edema. Okay, that regarding breast edema. Let us go for the vascularity effect. I am not an expert in this field, but since I started practicing breast ultrasound in 2003, I used to accomplish the grayscale method for evaluating breast lesion with both color and Doppler and power Doppler, okay? But I'm not using spectral type much, okay? I'm happy to share with you some again some of my experiences in this topic that I have discussed with you in previous breast imaging courses. I have prepared the remaining images from the literature. Okay, we will not talk about technique, only we will touch on some relevant information related to techniques, but we will concentrate on the uses and pattern of Doppler in breast. Okay. Different Doppler modalities used in evaluation of breast lesion, including a color Doppler, power Doppler, and spectral. And as you know, the color Doppler is easy to use tool available in most ultrasound machines. And here we can, usually the image display the 2 colors or more representing venous and arterial flow, or the flow toward the probe and flow away from the probe. And according to most of the machines, the flow toward the probe represented as red, and that away from the probe representing as blue. Okay, and so also can demonstrate, or we can get some information regarding the intensity of color depend on color shift. Regarding the power Doppler, is considered to be more sensitive than color Doppler to low flow. Okay, it's about 5 times more sensitive. And this is typical, the low flow is typical of breast lesions. So it is most advantage. It has most advantages to evaluation of the breast over the color Doppler. Since it measures the amplitude of blood flow, it is Doppler angle independent, okay, and avoid aliasing artifact. So it displays a single color, and it does not. That is why it doesn't. That is why, because it does not display information regarding the direction of flow. Okay. Spectral Doppler. Okay. As you know, we sample small area of tissue. Okay, and according to the spectral type of curve observed, it can give measurement of blood flow, and it can help in characterizing breast lesions. Okay, regarding the breast, normal blood flow in the breast are of slow velocity. Breast usually have small vessels and easily compressible. Even with gentle pressure, you can compress the vessel within the breast. Okay, so if during scanning, usually in the B mode, we are applying more pressure to visualize or to eliminate artifacts usually seen from the Cooper ligaments. But when you turn on the Doppler, we need to elevate that pressure, okay? And breast tissue usually increase vascularity in case of pregnancy and lactations, in case of inflammation and infection, and in case of malignancy, and some benign masses like intraductal masses, papilloma, or papilloma cases. And in case, I can add also fibrocystic case from my experience. Okay, this differential from the literature, but fibrocystic changes from my experience. From my experience, I have seen a lot of fibrocystic changes with increased local vascularity or diffuse vascularity. Okay, regarding the spectral wave imaging of the breast, as we mentioned, it has a slow velocity. So we have to see a very slow flow pattern with low flow velocities. See, the peak, we cannot see the peak systolic velocity very high. It is seen to be a little bit low, and it's also low resistant pattern with high diastolic. We can see the diastolic flow, okay, and low pulsatility signal of higher diastolic flow and shallow waveform. The waveform, it appears shallow. Okay. We discuss the conventional or the fundamental, okay, techniques regarding Doppler, the color Doppler, power Doppler, and the spectral Doppler imaging. Nowadays, there is a software that suppress the background and enhance the sensitivity of Doppler in breast. Okay, they call it microvascular or microvasculature imaging technique. This is the usual Doppler. In the same case here, we can see the microvasculature imaging that enhance and visualize smaller and smaller vessels that could not be seen in the color Doppler and even in the more sensitive power Doppler. And they also use another technique that by injecting contrast and then do Doppler study to enhance the vascularity, adding this enhanced juvenile fibroadenoma. The image is the color Doppler, This is not a power Doppler. This is also color Doppler after enhanced with contrast study or contrast injection, sorry. Okay, here we can see again 3 examples. This is obviously seen a suspicious mass in grayscale image, and this is the color Doppler of the same mass, demonstrate these feeding vessels and some of the branching with some aliasing. Okay, the color Doppler, as we mentioned before, we could not it is not associated with aliasing. Here again we can see the same vasculature or the same vascular signals could be appreciated on a color Doppler with a bit little more appreciation of smaller vessels. But when we see the superb microvascular imaging here, can you see even more details branching within the mass could be appreciated. So it enhances the microvasculature within the mass over the fundamental color and power Doppler. Okay. To obtain an optimal Doppler setting, we need to adjust certain parameters. One of these, we have to adjust the color Doppler box. Okay, the size of the color Doppler should be large enough to complete the surrounding area of interest, but it should be small enough to provide a color sensitivity. The smaller the color box, the higher the sensitivity. But we need to cover the area of interest. Okay, and if the color box is small and wide, you see, this will reduce the sensitivity, and at the same time, some informations can be of vascularity. It will be outside the box and missed during examinations. Okay, and in this case, we have also large box in relations to the lesions. It will result to, yes, it covered the whole mass and all informations, it will be appear if it get, if it can get us vascular signals, because when we use a large box, it will reduce the sensitivity and we might not get a vascular signal or a color signals. But in case of an optimum or correct size, and usually one finger on each side, right and left hands above and below at the same time, it's supposed to be like that, then this is, it will give a better sensitivity, color sensitivity, and it will give all information related to the vascularity related to the lesions. Here we can see this is small. It doesn't cover part of the lesion, even it is outside the box. We might lose, but because it is small, it will give better sensitivity. Again, this is a smaller one, give a good signal, but definitely this area, if there is vascularity here outside the box in relation to the lesion, it will be missed. While this an optimum one covering the whole lesions, okay, and demonstrate the vascularity, all information related to vascularity of the lesions. Also, we have to adjust the color box position, not only the size and its position. We should not angulate it, or we should not push it to one side like this one. Here, this is a big one, but it is pushed, you see, here it is larger than to that size. It's supposed to be the area of interest within the center of the color box, as in such example. Again, we have to adjust the color Doppler gain, okay? to optimize the setting and to have the gain as maximum as possible. This, but should not be associated with a noise. See, we don't like to have a color, to have a noise inside the color box as in these examples. You see, this is the gain is high. The gain here is too high, that associated with artifactual color echoes within the box, but we get a good color signals. Okay, while in this example here we have, you see, a lower gain, that the color signal, it will be weak. But in such example, okay, so there is no artifact, and at the same time we have a very good, okay, and a strong color signal. So the advice of the Doppler expert is that to turn the color gain up until noise displays. See, then to start to reduce it, turn it down until just the noise disappear. Then we'll get a clear image with a good color gain. Okay, if we see this example here, this is the same lesion seen here and again seen here. Why at the same setting, okay? Why, or at the same time, but different setting? Why here we could not appreciate any color signal, but here there is a good color signals? Okay, this is invasive cancers because they use too much transducer pressure. When we use too much transducer pressure, especially in breast, as we mentioned, the breast have a slow velocity, small vessel with a slow velocity. So it is easy to be compressed, okay, and occlude the lumen. Then we result in false impression of absent vascularity. So to obtain color signal in breast and breast lesions, it is necessary to use, okay, a light pressure, a light transducer pressure. Okay, it is needed to get a color signal. Okay, so not only that, as we mentioned earlier, we said too low gain might also result in false impression of absent flow. And the color angle, we need to use a correct color angle. If we use a 90-degree color angle, also we will not get a color signal. Okay, another things that we have to optimize the scale or the pulse repetitions frequency. And regarding the scales, it has to be adjusted, okay, and so as to avoid aliasing and to get a good signals. If it sets too high, it will not get signal. If the scale is too high, okay, it will not get signal. Why? Because the breast having slow velocities, okay, small vessels with slow velocities. So we need to get slow a lower scales. Okay. It is also necessary to adjust some other parameters. And as you know, the Doppler angles and Doppler shifts and all this will not go through that, okay? But at least the Doppler angles here represent the angle between the beam and the direction of flow in the vessels, and supposed to be less than 60 degree. Okay, so for Doppler, we need to have a high frequency transducer. Ideally, supposed to be 12 or 18. Why? Because this is capable of evaluating signal in vessels less than 0.1 in diameters and with low velocity, especially as we mentioned in the breast. So the higher the frequency, the better the sensitivity, the Doppler sensitivity. So we need to use the highest frequency that allow the penetration of the region of interest. Okay. Okay. Vascularity is to describe a mass or other lesions as hypovascular or hypervascular. According to the ACR, vascularity either present in a lesion, intra-lesion vascularity, or present immediately adjacent to lesions, rim vascularity, or absent. No vascular echoes appreciated in the color box. Okay, so categorization according to 4-point vascular scales, we have hypervascularity. If we look here, we have extremely abundant vascular flow signals within the color box, okay, or in relation to the lesions, either surrounding or intra lesions. Or in such examples, we have avascular mass. Again, we can see vessels in the adjacent tissue, but there is no vessels seen within the mass. Consider it as avascular. Hypovascular, we can see some small or weak vessels related to the mass. Here we can see this very, okay, and this is rim, okay, and the moderate, it will be in between the hypervascular and the hypovascularity. Okay. Cancer, breast cancer can be avascular, can be hypovascular, and usually seen with low-grade cancer. But also can be moderately vascular, usually in moderate grade breast carcinoma, and hypervascular, usually seen with high-grade cancers. Okay. According to Sigal et al., he demonstrated that benign lesions were found to be 2.2 times more vascular than normal breast parenchyma, whereas the malignancies were 5 times more vascular. So the more vascularity, the more suspicion. Okay. However, no vascular pattern is specific for any particular diagnosis. Okay. According to ACR, we'll go through these 3 descriptors again in more details, either absent or rim or intralesions. Here we have examples. We can see the color box, but we cannot see any color signal within the box. So we are dealing with absent. Excuse me, there is background noise. Okay, would you please close your mic? Okay, absent vascularity, not present or not assessed. If you, while reporting, sometimes if you do not assess the vascularity, you can say vascularity absent, not assessed. Okay, if it is not assessed, also considered to be an absent. Here we have 3 examples of absent vascularity. No vascular echoes seen within the color box. Usually seen with the cyst and with some benign masses or benign lesions. Okay. However, as we mentioned earlier, we have to consider our setting, okay, and technical factors. The pressure and all the gain, the scales, and all that stuff, we have to consider it to avoid the pitfalls. Okay. The second descriptor is internal or central vascularity. The central vascularity, it means that we can see a vascular signals within the mass, inside the mass, or inside the lesion. Okay, as in this example of invasive cancer, we can see here outside around or marginal around rim. Okay, we'll go to this descriptor, and all these vessels seen within the mass representing internal vascularity, but not only the mass. Here we have this in gray scales, this non-mass like lesion here with associated calcifications. When turned on the Doppler, they found that hypervascularity in the area. This is the power Doppler because we can see a single color. Okay. Here there is extensive vascular or color signal seen within the color box in a case of extensive DCIS. Yes, power Doppler improve sensitivity in detecting malignant breast lesions in such cases. If you turn up the color and you didn't get color signals, you can go to power Doppler, and most of the time you can get signals. The third descriptor is vessels in rim. Vessel in rim, you see, it means that vessels or vascularity related to the lesion at its wall or margin or a capsule. This we call it capsular or vessel in rim. Okay. This example of fibroadenoma, while this is my patients here, you can see rim in case of invasive cancer. This from literature, invasive cancer. There are variations. Okay. You can see here how does it look. It can be small, it can be full curvilinear or linear vessels, or interrupted like this. And this is also these examples here. This is a breast cancer. Look for the marginal vascularity, how it is big. The feeding vessels are big with aliasing here, while in this case here, these are two examples of abscess. The core here is devoid any signal, while the capsule of the abscess, okay, and the adjacent tissue demonstrate hypervascularity. Okay, as we mentioned, no vascular pattern is specific for any particular diagnosis. This is a breast cancer. Here demonstrate rim, okay, minimal vascularity in rim. The other one demonstrate minimal vascularity, moderate vascularity, rim, as well as intralesion vascularity. So here we can see two patterns. Here it is hypovascular, and this is moderate vascularity. And this, you see, considered to be avascular, because this is a little bit away in the adjacent tissue, not related to the mass at all. So this is avascular in low-grade breast cancer, and this is another necrotic, completely devoid of signal because it is a necrotic cancer. So malignancy can be cannot be hypervascular. It can be avascular, moderate, hypovascular, moderately vascular, or even avascular, completely avascular as in such case. While some benign lesions, such as papilloma, may be highly vascular, okay? And the most benign vascular tumor in the breast is a papilloma. This is, you see, solitary papilloma, intraductal papilloma within the nipple. Can you see it, how it is hypervascular? And this is an intraductal papilloma. You see, intraductal echoes can be caused by unspecific secretions or intraductal papilloma. So Doppler can help us to differentiate between the two and looking for the vascular stalks. Okay. This example, this is my patients of granulomatous mastitis. Look for the edema, you see, swollen hyperechoic fats and the skin thickening and hyperechogenicity, as well as the fluid, interstitial fluid. You see how much the interstitial fluid. And within these surrounding the ducts, and some of the ducts are dilated with hyperechoic material also seen in this area, and periductal extensive hyperemia identified. This is not inflammatory process, okay? However, different Sudanese female patients with aggressive breast cancers. Again, I have seen those during that period, 2022, okay? Look how this tissue, edematous tissue, okay, representing this is or associated with this extensive hyperemia. And here these are dilated subcutaneous lymphatics, okay, with large filling of color signals, even here with demonstrate aliasing, see, demonstrating aliasing, signifying higher velocity. Okay, so let us go and look together for the uses of color and power Doppler in the breast. And as you know, using Doppler ultrasound, the amount of blood to an area of interest can be assessed and compared to the surrounding area, okay? And increased vascularity, as we mentioned earlier, can suggest inflammations or malignancy. We'll go together through some of the examples. This is from literature. We compare here these two examples. In gray scales, these look more or less similar. But after using Doppler, it looks like a complicated cyst. This also can represent a complicated cyst, but turn on the Doppler. In this case, it demonstrates a peripheral vascularity in the wall and the adjacent tissue, but no central vascularity in a case of inflammatory or infected cyst. And even here supporting in the spectral image. But in this case, there is intra-lesion vascularity along with the surrounding vascularity, make it more suspicious, and it tends to be an invasive cancer. Okay. Anechoic Doppler is helpful when evaluating blood flow to cystic lesions. From here, it is obviously this is more or less simple cyst. Presence of peripheral minimal or moderate vascularity or even higher vascularity signify associated inflammation. Otherwise, there is no intracystic vascularity to make it suspicious. And this is even there is no any vascularity in a case of a simple cyst. Looking for these examples, okay? Regarding this one, here it seemed to be a complicated cyst. It looks to be a complicated cyst. There is internal echo with posterior enhancement, and there is some echoes seen within. We don't know if these internal echoes are related to debris or soft tissue component. By using Doppler here, we can see a color signal within the color box. So this case tend to be a high-grade invasive cancer. So color or Doppler is useful to evaluate such type of cystic lesions when we are in doubt. While in this example here, you see, if we look, it seemed to be anechoic. But what about the wall, the margins? What about the margins? Considering the margins per se, we have to grade it as a suspicious mass for biopsy. This is supported by color Doppler. And can you see how it is hypervascular?
البطاقة كم رمزها؟ أخضر.
What? Who is talking? You are welcome. Okay. High grade invasive cancer and metastatic lymph node may appear anechoic. And I have experience of one case presented to me after misdiagnosis of a necrotic lymph node in her axilla, reported as a cyst, because it was rounded and it was completely anechoic, but I don't know, they did not use Doppler, and they misinterpreted as a cyst in the axilla. Okay, so we need to use Doppler in such cases. It can be helpful, and if it is positive, if it is negative, it is not helpful. It is not useful, but it will be useful if it is positive. Okay, complicated cysts can be difficult to distinguish from high-grade malignant masses on B-mode or on grayscale ultrasound. Okay, so we have to follow systematic approach, looking for any features that might be worrisome to classify it as BI-RAD 4 or 5. Here, this one is indistinct at the end. Even if it is negative, we should not pass it as benign, okay? Because the margins are indistinct. And the margins demonstrate angular margin here. So the margin are suspicious, morphologically suspicious, and color, cut it short, make it highly suggestive of malignancy. Presence or demonstration of internal flow within otherwise simple appearing or complicated cyst confirm the presence of solid component and make it, okay, suspicious that require or warrant biopsy. Can you see this example here? Here it seemed to be cluster microcyst. If we look here, this like a cluster. And if you consider it anechoic with posterior enhancement, we might say that this is just a simple cluster microcyst. But after using Doppler, it was a high-grade cancer. See, so we have to be cautious while evaluating breast lesion or cystic breast lesions. And if we look for these examples here, okay, these are two examples, and this is the third one. This also, we might say this is debris within a cyst in a complicated. We can say this is the cystic part, and this portion might represent a debris. There is nothing, there is no bulge here, there is nothing. But after using Doppler, see, within the color box, okay, part of the lesions, there are signals that signify this is a necrotic cancer. This is a pseudocyst rather than a true complicated cyst. And here, this is again, this is a pseudocyst. Here, it seems to be hypoechoic, but there is some echoes here. Okay, this is a low-grade cancers. Okay, and there is no internal vascularity, but still we will not pass it as there is nothing, because if we compare these two examples, there is peripheral vascularity here away from the cyst in the adjacent tissue, and the same is seen here. But the difference between the two examples is margin. Margin always is the key. Margin is the key, okay? So here, this cyst has circumscribed margins, posterior enhancement. I will pass it as just a cyst, okay? Mildly inflamed or modified cyst. But this one, I'll not pass it as a complicated cyst, okay? Because of the margins. So we have to proceed for biopsy in such case. Again, using color in a case of cystic lesions. But in this case here, starting by this image, it seemed to be just a complicated cyst with fine internal echoes, okay? But in an elderly patient. But sometimes we need to adjust even the grayscale image, okay? And we need to use other techniques available in our machines, like harmonics and compounding, are really helpful. It will eliminate any artifact. If it is a simple cyst, then it will appear anechoic, it will appear clear. But if the internal echoes are real, it will enhance and will be visualized as a component, is an echogenic component within the cyst, as in this case. Can you see it now? It seems to be there is some solid component within the cyst, and if we follow here the margins, it seems to be like this. There is some protrusion, subtle protrusion here, suggests that this might be a fibrovascular stalk coming from a ductal system, obstruct the duct and causing cystic lesions, okay? And Doppler confirm the vascularity of fibrovascular stalk. So in such cases, we need to use a Doppler in a complex cystic solid masses to make sure looking for a fibrovascular stalk and exclude that is a soft tissue component, okay, in a complex or in cluster cyst. So if we have cyst like this, okay, it's not very typical simple cyst. We have to adjust our techniques to make sure, looking for any thick septations, any mural nodules, or fibrovascular stalks, looking for clustered microcyst, okay? And if we found any soft tissue or mural nodule, we have to look for any protrusions through the wall, okay, the regular wall. If there is any protrusion, that might suggest a fibrovascular stalk or papillary growth, whatever it is, benign or malignant, that extend from the ductal system into that cyst, and the cyst most likely due to the obstruction by that lesions. And also we have to look for any angular margins, okay, and any interruption in the capsules. And if we look here, This is the capsules, and at this point there is interruption and there is protrusion, suggesting before the Doppler suggesting fibrovascular stalk, and Doppler confirm the findings. Okay. Here it seemed to be these two examples seem to be complex solid cystic lesions. Okay, complex cystic with solid component, but this one avascular in a 73-year-old female, and this one demonstrate intra-lesion vascularity. In such case, it confirms that it is soft tissue because of presence of intra-lesion vascularity. And here it is obviously, can you see the duct extension into the ducts? There is a duct here. This is protrusion from the wall. Can you see the wall here? That is a cyst supposed to be the imaginary wall. It's supposed to be in this, okay? But here, okay, it extends into the ductal system. So this is a fibrovascular stalk. It can be neoplastic, it can be malignant, it can be benign. So it is either a papilloma or a papillary carcinoma. But what about this one? First of all, we have to make sure that we did not apply more pressure, okay? This is one issue. And we have to make sure that our setting was appropriate, Doppler setting, to make sure that the lack of vascularity was not technical. But even if it is all parameters and light pressure applied and the lesion was avascular, so how you are going to grade these lesions? Here, this is obviously, it will be suspicious. It will be BI-RAD 4, at least 4C, 4C for biopsy. But what about this one? Any suggestion?
I think it's also suspicious. Solid part, it's also suspicious. BI-RAD 4.
Huda?
Yeah.
Yes, excellent. Yes. Complex solid cystic mass is suspicious regardless of vascularity. Have you any explain for lack of vascularity? If it is, if I told you this is soft tissue component, not debris, it is obviously, it is most likely from the gray scales, we can say this is soft tissue. Why it is soft tissue? When things, it is lobulated. It is lobulated. Usually the inspiciated secretions and debris and all other components and soft tissue within a cyst doesn't give a lobulated contour. This is one issue. The other things does not extend beyond the contour of the cyst. If you look for the cyst here is oval, but at the attachment of this tissue, okay, there is extension beyond the wall, okay, and even some lobulations. The extension is not only in that way, there is also some angulation and lobulation here, make it even more suspicious, okay? So it will be, she's old lady, and with this soft tissue, this is definitely soft tissue, okay, within a cyst, with this appearance, grayscale appearance. So we are going to grade it as BI-RAD 4C for biopsy, definitely for biopsy. This is from both example from literature here, they consider it as suspicious, okay, intracystic papillary growth for biopsy, they recommend it. But this one, even they have the pathology result, and it was encapsulated papillary carcinoma. Okay.
This is avascular.
This is avascular.
Yeah, yes, avascular maybe or fibrous, more fibrous, rich in fibrous tissue,
Yes,
leading to loss of vascularity. Yes.
Yes.
Absence of color flow will not exclude this is a tumor or not.
You
Maybe
are
yes,
100%
yes.
And there is another issue also if it get necrotized. You see, sometimes necrosis of fibrovascular stalk get infected. Okay, if it is get infected, might not give vascularity because fibrovascular stalk can twist it. Okay, when it twists, it can get infarct and lack of vascularity. And the other cause, as you mentioned, fibrosis. Okay, excellent. Well done for me and you. Okay, evaluate cyst and complex solid cyst with solid component again. Here I have two examples. Okay, again, power Doppler, color Doppler demonstrate that the intracystic component are soft tissue due to presence of color signals. But I don't know, though here it is multipolar vascularity, but the diagnosis was papilloma from the literature. But this case, it was a papillary ductal carcinoma inside. Okay, this was suspicious. One of the function of color Doppler is to assess the intracystic lesion, evaluate, as we mentioned, for fibrovascular stalk. Okay, generally, intracystic malignancy have multiple feeding vessels, while benign having a single feeding vessels. Okay, this is my patient, and it was complex cystic with solid masses, and look for the vascularity. Okay, multipolar vascularity, and it was proven invasive cancer. Okay, this example from literature. If we look here, okay, it is a complex from the soft tissue component or from the intracystic component. It is obviously soft tissue rather than from the gray scale, I mean, or B mode. It seemed to be a soft tissue rather than inspissated secretions from that view, from this one. Here in this view, we might say before Doppler from this ultrasound view, we can say that it might be inspissated secretion versus from that direction, probe direction, this appearance of internal component, it can be inspissated secretion versus soft tissue. Okay, but presence of Doppler signals indicates that or exclude sludge or debris and confirm the presence of soft tissue component. But from these views, okay, I can say this is a soft tissue from these lobulations. Okay, remarkable lobulations suggesting that this is a soft tissue component. And if we look here also, okay, even where the attached of soft tissue, okay, there is multiple areas of angulation and extension into the adjacent tissue. If I look here, I might say this is the only extension. This is can be the ductal extension of fibrovascular stalk, but having these multiple areas of angular margin make it more suspicious. So this is highly suspicious lesion, and I might raise it to BIRAT 5, and it was proven to be intracystic ductal carcinoma. So one supportive suspicious features from Doppler study is not unipolar. Here I have multiple multipolar feeding vessels, okay, which is suspicious Doppler feature. So the teaching point here, malignancies can have benign features at ultrasound, especially high-grade invasive ductal carcinoma. It may be irregular shape, oval or rounded. It may be deeply hypoechoic, nearly anechoic, simulating a simple or complicated cyst, what is called pseudocyst. So here Doppler can help us. Literature reports over 3/4 of high-grade tumors have posterior enhancement. So the presence of posterior enhancement doesn't always mean benign. So it was considered as a benign features, usually seen in cystic masses, but high-grade cancers, in 3/4 of high-grade cancer, you can see a posterior enhancement. Most suspicious feature determines the final BIRAT assessment and need for biopsy. Margins are essentially important. As we mentioned, and we are always mentioning, margins are the key, margins are the key, margins are the key. Okay, complex solid and cystic masses are fairly uncommon. However, more than third are malignant. High-grade invasive ductal carcinoma, it might be associated with cystic spaces, giving description or appearance of complex solid cystic masses. It is a solid with a cystic component. However, papillary lesions are soft tissue component within a cystic mass or within a cyst, and it can be both benign. It can be not both. It can be either benign atypical papilloma or malignant papilloma, either papillary DCIS or papillary carcinoma. Here, Doppler differentiate intraductal component to be debris in case of these periductal inflammations. There is periductal hyperemia, okay? But there is no intraductal component, intraductal signal, color signal appreciated. So only demonstrate peripheral or rim vascularity in a case of periductal mastitis. While in these two examples here, we can see vascularity within the soft tissue component inside the duct, okay, that confirm the intraductal component is a soft tissue rather than debris in a case of papillomas. However, lack of flow does not exclude papillomas or other intraductal lesions. As always saying, presence of Doppler signals is helpful. Absence of Doppler is not useful. Can you see this is intraductal, okay? Extensive color signals, okay, within hypoechoic irregular tortual ducts in a case of high-grade DCIS. Also, color Doppler can be used to demonstrate inflammatory hyperemia. Here we can see these examples. You can see this irregular, okay, hypoechoic lesions with extensive surrounding edema. Look here how it is associated with hyperemia in this power Doppler, okay? In a case of phlegmons, okay? This is a phlegmon, a 35-year-old lady smoker with subariolar abscess, okay? This is the abscess only. This portion is an abscess, and the remaining is extensive phlegmon. And Then after the patient treated, then this hyperemia, it will subside. Okay, so the phlegmon, okay, is the tissue inflammations wherever in the body. The tissue inflammations, okay, we call it as is a phlegmon. When the phlegmon, okay, walled off with the peripheral granulation, forming a capsule surrounding a liquefaction portion of tissue, then we call it an abscess. So abscess has a core and a surrounding capsule, okay? And the periphery, the capsules, it will be hyperemic, and the adjacent tissue, it will be hyperemic, while the core, it become liquefied. So this represents the mature abscess. And sometimes even, this is my patients, you can see surrounding, and sometimes at the periphery of the mass, you might still see some vascular echo representing part of phlegmons that not yet completely liquefied. All these examples here, okay, of an abscess, look for the hyperemia in the surrounding phlegmons, while the core of the abscess or liquefied tissue, it will no longer be associated with hyperemia or with vascular echoes. So the core, it will be avascular, and the capsule and surrounding will be hypervascular. This is typical of breast abscesses. This is my patients, okay, having right lactational abscess complicating peripheral mastitis. Look for the hyperechogenicity, diffuse hyperechogenicity, swollen tissue with with compressed, okay? Sometimes the ducts become compressed from the surrounding edema. But if you use the probe to compress this, it will not get compressed because it will be rigid from that hyperemia, from that edema, surrounding edema and inflammations. And again, can you see extensive hyperemia surrounding the abscess? Because you see, and even we can see some mild at the periphery of the lesion representing non-liquefied phlegmons. And this is a case of a granulomatous mastitis, okay? This is my patients having extensive hyperemia here surrounding this hypoechoic area, okay, representing a phlegmonous, hyperemic phlegmonous. Okay, this is from the literature, hyperemia surrounding an abscess in a rare pathology of xanthogranulomatous mastitis, okay? This is a rare type of inflammatory process in the breast, okay? Doppler also used for differentiating benign from malignant lesions. And if you remember these slides, we have discussed it before, once or twice or more than that, okay? This is from my experience early on when I started using the Doppler color and pore Doppler to differentiate between benign and malignant, and I'm trying just to analyze the findings, okay? And I brought for you this case that was proven to be fibroadenoma, and this is 3 image of the same patient having invasive ductal carcinoma. And we said that if you look here, this is a marginal vessels, okay? And this is a branch of which, okay, in blue, and this is in red, okay? But it simulates the native vessels, okay? While in these examples here, the vessels is here it's irregular, it curves, and look for the branch, how does it looks? And there are multiple tiny scattered, okay, vessels. These the branching vessels are haphazardly distributed within the lesions, internal vascularity, okay, and it is disorderly or disrupted. That was my descriptions. Are disrupted, disordered, okay, distributed, numerous, tiny, are irregular, while these it seem to be intact vessels, and this is vein and this is artery. But if we look for this lesion at this point, look for these feeding vessels coming, entering perpendicular to the wall of the mass, look for the aliasing, okay, signify the high velocities, okay, and give a rainbow colors due to direct penetrating, traversing the mass here. See that our descriptions or imagining the difference between the two. This is more suspicious vascular pattern or vascular appearance, and this is more reassuring vascular appearance. If we look for the vascularity grading, you see, the two cases, it seemed to be moderately vascular. The fibroadenoma as well as the carcinoma, both are moderately, but the pattern of vascularity itself is different between the two. This is more reassuring, okay, while this is more suspicious type of vascularity. Vessel distribution was found to be equivalent for core and periphery of the lesion in case of benignity. Yes, according to the literature, they mentioned that the vessels within the core and at the margins, it seemed to be equivalent, while here we can see it seems to be different, more interrupted, more irregular, more chaotic or chaotic type. Aliasing is, okay, no problem. This is my patient also. Look for the vessels here. Okay, compare it with this. It seemed to be a complete vessels, but look for these feeding vessels here. Even in all directions, it seemed to be, it looks the same, not like this one, an intact, simulate a native vasculatures. Okay, this is also my patients. If we look for the gray scales here, from the first glance, we might say it might be a fibroadenoma. It looks circumscribed, but I was not happy. This is here. This is a patient having implant. This black area is the implant, and this is its capsule. She had a palpable abnormality. When I look for this, I was not happy. There is some angular margins. And look here, when I angulate, I can see again this angular margin. And it was not, I could not trace the capsule throughout this angular margin, and relatively deeply hypoechoic. It is not just gently hypoechoic, not slightly hypoechoic. It is deeply hypoechoic. I was not happy. When I turn on the Doppler, what I can see, the same, not an intact vessels, multipolar. There is vascularity from here and there is vascularity from here. And the more or the most vascularity from the area of angular margin itself, okay? And again, the vascularity is chaotic, is interrupted with aliasing, is not an intact when vessels are numerous interdigitating vessels. And even the vessels here within, it looks a large vessel, this vascularity, very large vascularity compared with the size of the lesion itself. Irregular, uninterrupted, okay? And are penetrating, not curving, not marginal, are penetrating, coming perpendicular, entering the mass itself. So I raised the level of suspicion, and it was proven to be an invasive cancer. So I considered the new vascularity. And as you know, cancer growth is based on new angiogenesis. The tumor induced development of new vascular network through the pre-existing normal micro vessels. These also my patients, for examples, is obviously seen here, this marginal, though it is very high vascularity, high flow, but it was a benign case, okay? Look for the vessels, intact vessels, okay, around the margin of the lesions, smooth, but look for the others, and even following the capsule is a capsular, but look for these 3 examples of cancer. The vessels coming perpendicular to the wall, and even, you see, interrupted. In these cases, coming and then interrupted, not seen within, interrupted. Why? Why? We can see the feeding vessels coming to the margin of a suspicious mass and then interrupted. If we look for all of these masses, examples are speculated, deeply hypoechoic, speculated. And usually we have seen speculated, less vascular in sclerous type of breast cancer, fibrotic one, as Dr. Rayah, our boss said. This is a fibrotic one, okay? So it compresses the internal vasculature. The sclerous cancer compresses the internal vasculature, so we have seen the feeding vessels coming and touch the margins of the cancer, and we could not appreciate some internal vascularity, only peripheral vascularity. Okay, this is also my patients here. And it was circumscribed but with imperceptible wall, okay? It was circumscribed with imperceptible wall. It was oval. I did not bring the B mode of the lesions. Sorry for that. But if we look for the vessels here, it simulates the normal vessels. It's intact, curvilinear, tubular, okay? Even if we consider it as a penetrating vessels, that it might be seen in some of benign lesions, but the branching within and extending intra-lesion vascularity, it simulates, it's more reassuring, simulate the native vasculature. And I have reported as BIRAT 4A. And usually I've seen such cases not because of vascularity, but because of cystic component. See, there are large cystic component within the lesion. And I have seen such cases with fibroadenosis. And the patient, if I remember well, she had a fibrocystic changes in some other areas of her breast. And that, if I remember well, it was proven to be a fibroadenosis, okay? This is from literature. If we look, this is a 18-year-old woman with recurrent bilateral giant fibroadenomas. These are recurrent fibroadenomas, but definitely we'll go for biopsy. We'll go for biopsy because not because of vascularity, but because of the morphology. The echogenicity and morphology and everything is suspicious. But it was proven to be just a giant fibroadenoma and even recurrent after surgical excision in both sides of the breast. In this case, you see, it's reassuring the vessels, though it's coming. Here I have seen it inside the lesion without seeing a capsular vessels, seen only. Also, these are suspicious types. I could see it within this one. It can be considered as just probably reassuring, but intralesions, vascularity, and even multiple interrupted like this, it will be relatively non-reassuring features. When we look for this example, from grayscale, you might pass it as just a fibroadenolipoma with mixed echogenicity, is oval lesions, something like that. But we have to be cautious. The margins are not circumscribed. Margin are not. And after using Doppler, look for the Doppler. It is from literature. It is not my patients, but I'm trying to analyze the case together. Look for the vasculature. It is a hypervascular. So this hypervascularity is not fitting with fibroadenolipoma. So I have to recommend biopsy. I'll grade it as PIRAT 4C for biopsy, at least. And it tends to be extranodal marginal zone lymphoma. This case, it was a lymphoma. So we have to be cautious while evaluating breast masses.
هي شكلها بتشبه الليمف نود، مش كده؟ هي ذاتها لو طريقت للجري سكيل تقدر تشوف فيها هايلاند في النص، تشبه الليمف نود.
Yes, but also it is more impressive of hamartoma. You see, here it is more elongated for yes, I agree with you. Lymph node, it can be like that, but you see the hamartoma in the breast, it's the breast with impressed appearance. We can see mixed of hypo and hyperechogenicity. And sometimes we can see even cystic changes within a hamartoma. It is usually like a fibroadenoma, but it will not be homogeneous like fibroadenoma. Fibroadenoma, it will be homogeneous, hypoechoic or isoechoic. But fibroadenolipoma, because of the presence of fat along with the glandular tissue and this, we'll see a mixture of echogenicity within the same lesions. In an oval lesions, sometimes we can appreciate a capsule, and sometimes even the capsule is incomplete. So from grayscale, without looking carefully and sweep throughout the margin to make sure about these lesions, it will be passed as a probably benign mass. But after vascularity, with this very high vascularity, we have to raise the level of suspicion. Okay, and it was proven to be a lymphoma. Okay, so regarding the vascular pattern on Doppler, color and power Doppler ultrasound in the breast, we have two main patterns. Okay, either a marginal pattern or a penetrating flow. A marginal flow, penetrating flow. A marginal flow, as we have seen it here, this is a marginal flow around fibroadenoma. If you remember, I have shown you this fibroadenoma early on after injecting contrast and repeat the color Doppler, they could appreciate these penetrating vessels. But seeing the penetrating vessels arising from a marginal or capsular vascularity even, it is a reassuring findings. usually marginal flow or rim vascularity seen associated with benignity or a benign pattern. We have seen a curved vessels around the margin of the lesion, not outside the margin in the tissue. No, within the wall, within the capsule of the mass, and usually seen with fibroadenoma. Okay, and the penetrating, okay, the penetrating flow is when we have seen the vessel perpendicularly, okay, penetrating or entering the mass from the edge. It's coming, traversing the center of the mass with or without branching pattern. Okay, and this is usually seen with the malignancy, and that is why considered to be a suspicious finding, seen with the specificity of 95%, predicting malignancy. Though it can be seen with benign, because still we have 5%, and usually when seen with a benign lesion, it will be a papilloma. Okay. However, some these are dominating for benign and dominating for malignancy, with some little overlap regarding this location and morphology of the detected vessels. Again, this is various examples of capsular, okay, vessels. We can see it in a fibroadenomas. These are different examples. And there is another pattern when we have seen the parallel artery and vein signs. Excuse me, this is supposed to be. I don't know, it was. Okay. Here we can see this is representing vein with this is representing artery with adjacent vein. Again, here we can see artery and adjacent simulate the native vessels, intact vessels. This and even here we can see the spectral Doppler of vein and spectral Doppler of artery. Okay, can confirm the presence of artery and vein. And this is, it can be peripheral or it can be central, okay? And it denotes normal anatomic conditions. These signs of parallel arteries and veins are described as reliable features of benignity in a solid mass. And it has a specificity approaching 99%, okay? These examples of extensive parallel artery vein sign in a papilloma, okay? In a benign papilloma. And here these multiple examples of parallel artery vein signs and can be seen in fibroadenomas, papillomas, lactational adenomas, lymph node, and among others. But these are the common examples, okay? Here we can see 3 fibroadenomas with a parallel vessel sign. This is in young lady, and we can see it more or less oval shape, but even here, it is an irregular, a little bit irregular with some lobulation, and the patient was old, and same, this is indistinct, but because of morphology, definitely, we have to proceed for biopsy, and it was proven to be a fibroadenoma with this benign Doppler signs. Another examples of a benign Doppler signs, okay, in a case of lactating adenoma. And usually, as you know, lactating adenomas have a suspicious morphological features, and most of the time it is a hypervascular. Okay, but any rules have exceptions, have an exception, or have exceptions, okay? And we have to be cautious. If the lesions, I will consider the Doppler benign signs if the morphology is benign. If the morphology is not benign, I will not consider the lesions benign because of the benign Doppler features, because rarely this parallel sign is not 100% benign features. Still, there is small percentage of malignancy can be presented with such benign features. Okay, and these patients here, 47-year-old lady, you see, in a case of a phylloides or borderline phylloides tumor. And these patients here, when we have seen numerous vascularity, hypervascularity, we have to think about, in a benign appearing lesion, we have to think about papilloma. And this 38-year-old lady with a papilloma, okay, but is not morphologically, I'll not go directly to benign, or probably benign, because still, though it is parallel oval, but it is some cystic changes are seen, and even the margins not completely circumscribed. Some areas of indistinctness can be seen. So it's proven to be a papilloma associated with DCIS, demonstrating the parallel artery vein signs. What about this one? Is it parallel artery vein sign? Definitely no. We are not going to consider this parallel. These are penetrating vessels. And can you see it here from, okay? These are penetrating vessels in invasive multiple invasive carcinoma, demonstrating multipolar. You see, the feeding vessels are multipolar and are penetrating, interrupted, chaotic, and all features suspicious. Okay. The morphology of vessels of solid breast on power or color Doppler was described by Raza and Baum. They found that the sensitivity with specificity, positive predictive value, and negative predictive value of using penetrating vessels to predict malignancy, 68, the sensitivity relatively low, in spite that it was a power Doppler. Specificity, 95%. Penetrating vessels highly specify for cancer, but not indicate cancer. Still, we have 5% can be seen associated with benign lesions, and mostly papilloma. 85% positive predictive value and 88% negative predictive value. And here we can see multiple penetrating vessels. When we saw multiple penetrating vessels, it's even been more highly suspicious or more highly suggestive of malignancy. Can you see? These are multiple, this branching, but these are multiple penetrating vessels. Again, if we saw intra lesions, vessels without seeing the feeding vessels or capsular vessels, it's also a suspicious feature, especially if these vessels are chaotic in distribution. It signifies, and tortuous, it signifies new vessels or neoangiogenesis, and strongly increase the BIRAD scores. If you have seen such type of vascular pattern, morphological distribution pattern, we have to raise the level of BI-RAD score. Okay, here we can see multiple afferent vessels. From outside, we call it afferent vessels or feeding vessels coming. If we consider this is fibrovascular, okay? If we consider this cyst with fibrovascular soft tissue, okay? Then if we have seen vascularity multiple than one vessels, it will be more suspicious. It will be, we raise the score of vascularity. And even here, it is multipolar, okay? So malignant tumor secrete angiogenetic factors, stimulate growth of abnormal blood vessels from pre-existing microvessels, okay? So develop more vascularity to supply it, to support its further rapid growth. That can be seen in such cases. Again, here there is absence of capsular flow. We cannot see capsular flow, but we can see internal vascularity, abundance of internal vascularity without capsular flow. Again, this is highly suspicious features. And the only exceptions of benignity is papillomas. If we have seen this, okay, in a benign appearing, it's still we report it as suspicious for it can be papilloma or malignancy. But if it is underlying morphological suspicious lesion, then it will be more suspicious, increase the score of suspicions. Okay, here we can see different examples from the literature demonstrating malignant pattern of vascularity. It's hypervascular with large feeding vessels, okay, and irregular branching, interrupted, and central new vascularity, irregular, chaotics, scattered, peripheral, central, all of malignant appearing new vascularity can be appreciated in these examples, and this we can see the vessels coming to the margin, penetrating vessels, or these irregular feeding vessels, but interrupted inside, suggesting that this is most likely Skirras type breast cancer, especially it is so speculated. Okay, here we can see hypervascular primary with hypervascular metastatic lymph nodes. In 85% of breast cancer, metastatic lymph node have the same histological type as the primary. If the primary hypovascular, the lymph node will be hypovascular. If it is hypervascular, it will be hypervascular. And even the spectral waveform, it will be more or less the same. And as you know, angiogenesis, okay, the process of new blood vessel formation plays the central role in both the tumor growth, invasions, and distant metastasis. So the tumor development, it is invasion, and the metastatic process attributed to new angiogenesis. That is why I can explain the metastatic lesion having the same radiological pattern and appearance of the primary lesions. Regarding the spectral of breast lesions, here we have the benign pattern, and this is a malignant lesions, okay? If we look for both usually in malignancy, as we mentioned, hypervascularity, large feeding vessels, central vascularity, neoangiogenesis, and resistance, it will be significantly high with low diastole, low or absent diastole. Okay, as we have seen here, and there is also high pulsatility, and the waveform will have little to no the diastole with deeper slope. Okay, the slope, it will be deeper, and high flow velocities. Here we can see the high flow velocities, okay, with absence of systolic velo. Compare it with the benign. The velocity, systolic velocity, a little bit low, and there is a diastolic flow. Again, this is a malignant mass. The peak systolic velocity 24, resistive index 0.8, it is more than 0.7, okay, and pulsatility index is 1.2, and the spectral Doppler here can detect small vascularity in MS, okay, such as penetrating vessels. If we compare, look for the velocity, and you see high pulsatility, and if we compare it here with the normal appearance of the breast, look for the diastole here is a little bit shallower, and the velocity, the peak systolic velocity here is much higher than the normal breast. Again, here, these are two examples of, this is two images of the same breast mass, okay? But we have peripheral and central vessels. Each vessels represent a waveform separate from the others. This one relatively near to the normal breast waveform, but this one demonstrates shallow diastolic with high velocity and pulse repetitions and all these stuff of malignancy. Okay, so the identification of an indeterminate mass with benign Doppler, how we can use Doppler to help us in characterizing and categorizing the breast lesions. Because some literature saying that intratumoral vessels was significantly associated with malignancy. Others said that color Doppler signal in a lesion otherwise thought to be a benign should prompt biopsy. But other literature say that increased vascularity on color Doppler sonography cannot be considered as a sole factor to establish the diagnosis of malignancy. So there are contradictions, but how we can use it to help ourselves. This is benign appearing. If it is benign appearing morphology and benign appearing color pattern, distribution and pattern of color flow, then it will be reassuring to follow the case reported as BIRAT3 and follow the lesions. If the lesion morphologically probably benign, has more benign morphology for the first time, soft tissue mass, then it will be BIRAT3. If it is avascular, this also be reassuring. Okay, it allows us to recommend ultrasound follow-up rather than go for biopsy. But if the underlying lesion is borderline with some suspicion, okay, morphological suspicion, and associated with vascularity, it will raise the level of suspicion. And if the pattern of vascularity, okay, is suspicious pattern, then it will further increase the score of biopsy, and then it will indicate biopsy. It will warrant biopsy. Okay. Here we have example from literature. This example here, okay, was diagnosed. This having calcification on mammography, okay, and reported as BIRAT 4B, borderline, slightly suspicious. Okay, ultrasound demonstrate these patchy areas, okay, of non-mass-like lesion, hypoechoic focal. It seemed to be a little bit segmental area. Okay, while here on the automated breast ultrasound, it seemed to be more or less focal. It might be because this is a coronal image and this is axial image, okay, in the upper outer quadrant of the breast. But there is no obvious associated vascularity. Since there is no obvious associated vascularity and no more suspicion features, it will be borderline. It was graded as BIRAT 4A. It was downgraded from 4B to 4A. Okay, but in the other example here, same findings, though no calcifications, but there was asymmetry on mammogram, reported as 4A on mammography because just it was focal asymmetry. Ultrasound demonstrate this segmental area of non-mass-like changes or non-mass-like lesion, hypoechoic. It also seemed to be a little bit segmental or regional, and here it seemed to be focal because also this is EBUS, a coronal view of EBUS. Okay, it is in both. It is a heterogeneous, non-mass-like, but in the other example, associated with hypervascularity. There is moderate increased vascularity. I can see a vascular signal, significant vascular signal within the color box in this example. So from BIRAT 4A in on mammography, upgraded to 4B on ultrasound. This example, how Doppler can help us in evaluating breast lesions. This lesion here, we can see it. It was in the axillary tail. It seemed to be cystic lesions in the axillary tail. And as if there is something extending from here, we might say complicated cyst or cyst containing fibrovascular stalk. We don't know exactly what could it be, okay? Or this is vessel coming into a large lymph node, we don't know. So using the color Doppler demonstrate hypervascularity. So it will raise the level of suspicion. After biopsy, it was proven to be a metastatic lymph node, okay? Because if we look for the vascularity, this is not the normal hilar pattern of the lymph node, okay? This is examples also here, okay? Two lesions. This is one lesions and another lesions, okay? The two lesions, this is the same as this one. One small, one large, the same patient, lesion 1 and lesion 2. Okay, are morphologically suspicious. And using Doppler, look for the Doppler. This is even more suspicious than this one. Why? Both demonstrate peripheral slight vascularity, slight peripheral vascularity. Okay, foci of vascular echo seen at the periphery of the lesion. But this lesion demonstrates multiple foci at the periphery and at the center, both. It has multiple feeding vessels and are interrupted, multipolar. So it make it more suspicious, okay? It will make it more suspicious, and then it will upgrade the lesions. It was reported as BIRAT 5 and proven to be invasive lobular carcinoma grade 2, both of the lesions. Okay. If we look for this irregular mass, we can see it in inflammatory, like granulomatous mastitis, or in neoplastic process. But after Doppler and the pattern of vascularity here, I have seen large penetrating vessels. Definitely, I will upgrade it to BIRAT 5. So this is not the pattern of inflammatory process. This is a pattern of neoplastic process, and it was proven to be invasive ductal carcinoma. And this example, abscess sometimes can be seen like this. We have seen a lot of abscesses looking like this, irregular, indistinct, and heterogeneous, deeply hypoechoic with some internal echoes, but still cancer can look like this. So let us go to Doppler. Using Doppler here, this is not the pattern of abscess vascularity. Abscess vascularity, I'll see marginal vessels at the capsule and the adjacent tissue and completely devoid vascularity within the core. Here I have seen multiple peripheral feeding vessels with a branching vessels penetrating into the mass. So from this vascular pattern, I will upgrade the lesions, okay? And then it was proven to be an invasive cancer. So while benign breast lesions exhibit mature native breast blood vessels of harmonious architecture, usually marginal or capsular blood vessels of straight or curve with regular caliber and harmonious distribution and parallel vessel sign or parallel vessel pattern. Okay, these are associated with benignity. Malignant angiogenesis generate a local vascular network, dense in capillary and arteriovenous loop and shunts, resulting in tortuous, irregular caliber, disorganized new vessels with chaotic distribution pattern. As we mentioned, a vascular nature of a lesion with benign morphology, i.e. BIRAT 3, without color signal, often correspond to cyst with thick content or to fibroadenoma. In most cases, these signs reflect benignity. So it allows us to recommend a follow-up rather than proceed for biopsy. On the other hand, suspicious or doubtful morphology, BIRAT 4B, C, or 5. We are not always able to visualize intralesion vascularity. And in such case, okay, aberrant avascularity does not exclude malignancy. It doesn't mean benign. We have to proceed for biopsy based on morphological criteria. As for a number of afferent blood vessels, benign lesions tend to have one peripheral vascular ball, however, still there are some overlap between benign and malignant lesions, and therefore the current ultrasound lexicon recommends evaluation of lesion vascularity, but it is not mandatory. Okay, both color and power Doppler are complementary to the grayscale ultrasound. Doppler can also help us in evaluating neoadjuvant therapy treatment. Okay, and as you know, neoadjuvant is important or essential for the treatment of local advanced breast cancer. Okay, we need to evaluate the response of the treatment if the lesions affected by the treatment or resistant to the treatment, and Doppler one of the methods that can help us to evaluate the response, especially it gives us impression of functional effect because the size of the lesions might not be affected in early conditions or early after treatment. The size, because of the effect of treatment, might result in necrosis and fibrosis, and this even not only hinder the regression of the lesion size, but might give apparent impression that the lesion is getting larger. But by applying Doppler, the viable tissue will demonstrate vascularity, while necrotic or dead or fibrotic tissue doesn't show significant vascularity. And especially if we compare it with the baseline ultrasound, we'll see how the feeding vessels regressing in size, and even the color changes and spectral wave changes might be affected. So because they attack some of the, especially for the treatment, the angiogenesis therapy, okay? The angiogenesis therapy, it will regress the process of angiogenesis and the vascularity of malignant lesion, as we mentioned, attributed to this process, and definitely is going to be regressing on a follow-up, as we have seen in this example. Look for the feeding vessels, how getting smaller in post-treatment image. So also helpful in evaluating post-surgery. Okay, here we can see this is immediate post-surgery seroma cavity surrounding, because the post-surgical inflammations, we can see rim of vascularity. And this vascularity later on, because the inflammation is going to be subsided, and then it will disappear, this vascular echo. So if after disappearance or later on the patient demonstrate any vascularity, it will be worrisome, it will be suspicious, and we have to work up. As in this example, here demonstrate internal vascularity in the surgical scarring, extensive vascularity due to recurrence. Okay, so look for, this is post-surgical, look for the marginal vascularity indicative of benignity, while these penetrating vessels going with suspicious Doppler features. Okay, and here no surrounding vascularity, as we mentioned. Looking for this example, color Doppler of fat necrosis at lumpectomy sites. Okay, demonstrate no vascularity. Evaluate lymph node. Doppler helpful in evaluation of lymph node. These patients from the literature, okay, they found a lesion in the upper outer quadrant, oval, parallel, but not very typical of lymph node. It doesn't show the hyperechoic hilum. So by applying Doppler, it demonstrates typical hilar vascularity of lymph nodes. So it helps us to define that it is a lymph node. This is my patients. Also intramammary lymph node, but here it is obviously is not a normal lymph nodes. That is the hilum, but look for the focal, asymmetric, cortical dilatation, which is deeply hypoechoic, and look for the vascularity. Though it is hilar vascularity, but it's significantly large. If it's only large vascularity, it will not be, it can be just hyperactive. But regarding the cortical changes, so it will be suspicious, and it was proven to be, though it is small, it was intracystic. Sorry, it is metastatic. It was metastatic intramammary lymph node. This is also my patients, okay? Within, if you look here, within the breast, toward the axillary tail, I can see a rounded instead of normal oval. Being rounded, it will be suspicious. Then when I used color Doppler, look for the vascularity. Look for the vessels coming from the hilum and how it is hyperemic. Okay, it raised the level of suspicion, but not that the hyperemia only, but the morphology and the presence of capsular vascularity. Capsular or peripheral vascularity in the lymph node is the one more suspicious than just increasing hilar vascularity. And here we can see the peripheral vascularity in different view of the same lesion, and adjacently when we search, or firstly, I was detecting these lesions, the lesions. When I put the color, I found that this is a lymph node. So I got impression that this a malignant lymph node, and I was starting searching for the primary. When I curve here, these lesions, it was from that angulation, it was completely hyperechoic from one angle. When I angulate, I could appreciate that within that extensive hyperechoic reaction, there is an irregular hypoechoic needles within, representing an invasive cancer. Okay, and even look for the vascularity here of the lymph nodes. This, it was, and here it is disorganized. Though the majority of vascularity coming from the hilum, but it seemed to be disorganized. And as we mentioned, the presence of, if we compare it with this one, this is also my patient. But look, this, yes, hypervascular. It is a hypervascular, but the vascularity coming from the hilum then is extend toward the cortex. In a case of a lymphadenitis, a reactive lymph node, it was proven to be just a reactive lymph node. There was no peripheral vascularity. The vessels from the hilum extending toward the periphery because of hyperemia associated with inflammations. And this one, can we see here? There is hyperemia. There is increased vascularity, okay? From, what do you think about this case? This one. Again, it is only, or it is mainly this hilar vascularity, increased vascularity. But still it is suspicious. Though it is hilar, when I compare it with this one, this is suspicious. Although here I have high flow, okay? But look for the vessel itself, okay? Look for the irregularity. And the lymph node indistinct and deeply hypoechoic, okay? This case associated with this inflammatory carcinoma. here, this is the mass and diffuse edema. We have seen this case early in the edema, okay, sections. And this is the lymph node associated with that one, okay? And definitely this one is highly suspicious and proven to be metastatic cancer. Okay, looking for this, these are lymph nodes. This is, we have seen it just now, the reactive or adenitis, hyperemia or increased vascularity, central or hilar vascularity. And if we look for this one, also I can see increased hyperemic lymph node, but it's coming, all the vessels coming from the center going toward the periphery. I couldn't see any marginal vascularity, okay? And these two examples here, my patient and the case from literature, proven to be just an inflammatory lymph nodes, having normal branched hilar flow or central high vascularity or hypervascularity. But in this example, definitely there is the majority, maybe this is the remaining of the hilar or central, but the peripheral vascularity is much more impressive than the central vascularity. So since I have seen the major hilar one, we call it mixed vascularity, mixed hilar and non-hilar vascularity, or central and peripheral vascularity. Presence of peripheral vascularity in a lymph node is highly suggestive of malignancy. It represents peripheral vessels entering the thick cortex of metastatic lymph nodes. Okay, as you know, the invasions of lymph nodes coming through the afferent, through the cortex. So these are associated with the vascularity coming also from the cortex peripherally. Okay, this we have seen it just now. And look for this one. This is, here we can see two colors or more than one color. So we are dealing with color Dopplers, okay, demonstrated. And here I can see this is again lymph node, but this is a single color. So here I am dealing with power Doppler, demonstrating extensive peripheral vascularity. This is capsular. This sign, when I have seen it, and when I saw this sign in a breast lesion, is a reassuring sign. Capsular, but this sign in a lymph node is the reverse, is a highly suspicious sign, especially with this hyperemia. Okay, it is highly suggestive of malignancy, metastatic lymph node, highly suggestive of metastatic. What about this one? What about this one? As we mentioned, the power Doppler is more sensitive than color Doppler for the low flow and can detect minimal flow, capsular flow in the lymph nodes. Okay, by power Doppler, here it is hypervascular, large vessel, but even if our small vessels could not be detected by color Doppler, power Doppler will enhance visualization of these vessels. But however, still, power Doppler does not provide information about the direction of the flow. Okay, and even the small vessels within the nodes. But here we can see, can you see the hilar vessels? And you can see these branchings, okay? The microvascularity, the microvascular technique. Do you remember at the beginning of the lectures, we have mentioned that there is a new technique, the microvasculature technique, enhance the visualization of small vessels. And here we can see the vessels entering through the hilum, and these are progressively smaller branching, okay, seen toward the cortex. So it proven to be with these branches, we can be reassured that is a unipolar vascularization. It's only central vascularization rather than any associated peripheral or capsular vascularization. Okay. This is a power Doppler sonogram showing lymphomatous lymph node with both hilar and peripheral arrowhead vasculature. I don't know. I will ask you, Dr. Our boss, Dr. Rayah. I have seen more than one color here, but this is from literature, and they report it as a power Doppler rather than color Doppler. Why? And I know that there is the power Doppler neither give information about the direction of flow nor giving aliasing artifact. How can I explain different colors in this image? Okay. Dr. Rayah is there or he left? Okay, he might go for prayer.
Yes, no, I'm there. Or I'm here. Okay. Okay. This is actually it is strange, yani. But from the look, sometimes I can see the power Doppler in orange. All the image, all the colors are in orange, unicolor, or in blue as here. But here both colors are present here. Yes, but I don't know. Maybe it is not a power Doppler. Maybe other modes. I don't know.
Okay.
Or yes.
Okay, we can search. We can search about that to know what is the cause for this. I don't know. For me, from the beginning.
Yes, these are two directional. This is a two-directional flow. Okay.
Which is unexpected. Which is unexpected in power Doppler.
Maybe missed as
mislabeled.
As normal. Yes, mislabeled. Yes.
Mislabeled. Yes. It is color, but mislabeled as power.
As power, yes.
Yeah.
Yes.
Yeah. Thank you.
Okay.
But if it is color, it will be high flow. Yes.
Yes, high flow. But seems to be more regular.
More regular. It is.
Yes, it is not a new vascular for me.
It is not. No, we have the new vascularity peripheral here.
Yes, but inside the lesion, yes, it is so regular coming from the hilum. But if you look outside the lesion, yes, you can see peripheral vascularity. Yes.
Boss, one more comment. Even at the hilum,
yes,
I cannot see. Let me show you. Here, I can see the main vessel.
Yes.
And these are the branches. Okay. These are the branches. But here from the beginning, crowded as the hilum, I can see numerous vessels, though it appears like the native vessels, but are too much vessels, feeding vessels at the hilum. Okay, and these feeding vessels then branches. I think this is also abnormal. These are abnormal in the term of the number, not on the appearance of vessel itself.
Yeah, yes. If you look to the vessels, they are seems to be more regular.
Yeah.
But as you mentioned, you don't know where is the entrance from here. It is not.
The main,
it is not straight.
yeah.
Yes. Yes.
Yeah, the crowded of branches at the hilum suggests that
Mhm.
all these are an abnormal vessels
Mhm.
rather than just a branches.
I
And
see.
this can be supported by the presence of the abnormal smaller peripheral vasculatures.
I see.
Non-hilar is abnormal. Okay, thank you very much for your response and discussions. Nice discussions. Okay, it is obviously from morphology, it's suspicious. Okay, and here they mentioned that they have mentioned a 54-year-old woman with history of remote ipsilateral breast cancer and recent significant trauma to the upper arm. Okay, so they are expecting to be it can be either represent recurrence, metastatic node versus reactive from the trauma. So how we are going to report this or to grade it? We are going to grade it as suspicious. Okay, it is type 4 lymph nodes with very thick lobulated cortex, but regarding the vascularity, it has unipolar vascularity. This one is unipolar. We can see a single vessel through the hilum and then branched. So still the vascularity of benignity, though the morphology is highly suspicious, and they found to be just a necrotizing, benign necrotizing lymphadenitis. Okay. Okay. So regarding the spectral, can you comment, Dr. Rayah, regarding the spectrum of the lymph nodes? Definitely, you are going to give us more information than me. I'm not so expert in the spectral. This is the normal. This is the benign. I mean, the benign unipolar. Yes, the unipolar hilar vascularity. While this definitely abnormal vessels. Okay, this is new vascularity in a metastatic lymph nodes. So here the velocity is high. We can see it is high. Okay, and it is the pulsatility is very high. Well, velocity ranging from minus to plus. And the very low diastolic flow. If we look here, this is the diastolic flow in the benign one, while here there is almost no diastolic flow. Okay, and if we look for the benign one, benign lymph nodes, the peak systolic velocity is a little bit lower than seen in this malignant lymph nodes. Okay.
Okay. Yeah.
Okay.
Yes. Here in this, as we mentioned earlier, in this malignant lymph node, there is the low diastolic blood flow, indicating there is high resistance. That means it is more fibrous than the benign one. The benign one showing a relatively high diastolic blood flow, indicating that this lesion is of low resistance.
Yeah.
It is more spongy than the previous one.
Yeah.
So this is why here in the first one is increased resistivity index, and here it is a low resistivity index.
Yes, you are right. The infiltrating lymph node, it will the lymph node tissue, it will not be the normal sponge as you mentioned. It will be replaced with the malignant cells. So it will give a peripheral resistance for the vascularity.
Yes.
Yeah. So it will be reflected. It will be reflected by a high peak systolic flow and with diminished diastolic flow. That is the meaning, yeah?
Yes. The high peak systolic flow indicates there is more need to push the blood inside the node. Okay. So here the flow velocity is increased. And
Means what? Sorry. It means what? There is no.
Here there is a need for a force to push blood inside the high resistance node.
Yeah.
Okay. So here the flow velocity is going to be increased to push more blood inside the high resistance lymph node.
Yeah.
Okay. Whereas in the other one, the benign one, there is an optimum pressure needed to push the blood inside the normal lymph node.
And that is why it is repeated two nerve. Yani this peak with this peak, and the repetition is so frequent. The frequency is high also. Yeah.
Yes, the high frequency also, and
because of the distance resistance. Yeah.
Yes, and the peak systolic flow velocity is reached in less time, while you can see in the other graph, the peak systolic flow velocity is reached at much ease time. Yeah. I don't want to complicate it for you, but this is the nature.
Okay.
Yes, this is the nature of the
no, it
malignant
is
lesion from the benign. Yes.
You explain it simply. You explain it simply. I could understand. Thank you very much, Yabas. Thank you very much. Okay. Other uses of Doppler. Evaluate vascular lesions. Here we have two examples of pseudoaneurysm. This one was small, okay? Just with pressure, get clotted, and with compression for half an hour, it disappears. The flow disappears. Again, here we can see the box, the color box, but no more significant color signal appreciated after compressions because it is small, just treated with compression. But the other one here, we can see a big pseudoaneurysm. Okay, in a 55-year-old woman who recently underwent ultrasound guided biopsy. And the grayscale and color Doppler over the biopsy revealed large heterogeneous fluid collection. Here we can see large heterogeneous fluid collections. And here we can see, we can see two colors. And we can see here, this is the neck of the aneurysm. And there is to and fro flow, okay? So it seemed to be coming in and coming out, the vascularity. So I have two directions flow. That is why I have two colors, the blue and red. And a positive yin-yang signs. According to, from the literature I brought for you, this is the yin-yang signs, you see? So we have white and black signs here. So it represents something. There are two opposites signs interconnecting. And here we have two direction of flow and seems to be interconnecting. So because it is large, they send the patient for interventional radiology for the management. And here we can see another pseudoaneurysm similar to this one. And that is after treatment. You see, there is no more internal vascularity of this pseudoaneurysm. Okay, also it can help us evaluating the superficial veins for thrombophlebitis in a condition called Mondor's disease. Okay, this is my patients presented with a tubular or nodular, like beaded appearance or beaded bulbable abnormality in the upper outer breast, left breast. Okay, and on Doppler examination demonstrate this very superficial, just below the skin, tubular hypoechoic beaded structures with a lack of Doppler signal seen within. Even the spectral signal demonstrate nothing. Flat, it was flat. There was no any vascular signal could be appreciated in any of color, power, or spectral signals. And this is, we call it a Mondor disease, and we have to be cautious if we have seen this thrombophlebitis in the breast to search for any underlying causes or etiology like breast cancer. It can be associated with breast cancer, but sometimes can be even related to trivial trauma, like something hitting the breast, or even by her child while lactating, hitting her breast or so. Okay, and we have to be cautious and to differentiate it from ducts. Okay, but usually ducts are arranged in a radial direction, not parallel to the skin. But at one point, the duct can be parallel like this, but try to trace that duct, you will definitely follow it reaching the nipple. While this one, it will not, it will be interrupted. It will not go into the nipple areolar complex. And look for this duct, it's curving, not like the vessels. When we talk about this thrombophlebitis, we are dealing with the superficial, okay, venous system. In the breast, as we discussed in the anatomy, we have the venous system, we have two systems. The superficial one, only venous structures, while the deep system, that one parallel the arterial system. Okay, this lady here, a 40-year-old or in her 40s, presenting to me complaining of a throbbing pain in a palpable abnormality in the right upper outer quadrant. When I scanned the patient, I could appreciate a tubular, anechoic, or hypoechoic structures. When I turn on color Doppler, I could appreciate this intense vascular signals in tubular structures like vessels with aliasings. Okay, it is predominantly red with aliasings. So from my impression, I suggest that it is a high flow rather than a low flow vascular malformation. So very unlikely to be a venous malformations. What is your impression regarding these lesions? Dr. Rayah and all of you. What do you suggest?
No one? No one from the audience?
Any of you have any impression? Or
Okay.
has any impression?
Okay. طيب انا والله في الحقيقه دي this is a very very good image to comment on back into أسئلته حاجه اللي هي قلته الفلو velocity from colors. Okay. But this is a very good image, good example to comment on this flow velocity from colors. As you can see here downward, there is a blue color.
sorry دكتورة ريح. Before you proceed, أحب أضحك في نفسي. This case I have reported long time, years, and yesterday I asked in the group about how could I identify the velocity from the color.
فهنا انت you have to estimate the color from the color, just estimation, just not a clear cut يعني how much يعني this flow velocity in figures. Okay, you can see there is a blue color.
Yes.
Which is the least flow velocity here in this vessel. Okay.
Yes.
Near the blue is almost red to orange. مش كده؟
Yeah.
Yes.
And faint green. And even this color also faintly visualized.
Yes. And here when you go from blue to red, this is increasing blood flow. Okay.
Yeah.
Increasing flow velocity. Sorry, increasing flow velocity. When you go to the near yellow or orange, this is more
high.
This is high flow velocity than the red one.
Yeah.
But if you reach the green one, this is very, very high flow velocity, extremely high. The green one.
There is faint green at the periphery here. Very faint, yeah.
Yes, this is the.
Can we consider this aliasing presence of these mixtures?
Yes, here aliasing يعني أنا أسهل لكم الاليازنج دي طبعا مرات بتلخبط بالذات الواحد لو بيدرس في الفيزيكس. بتلخبط عليك. تخيل عندك ورقه بتاعت رسم بياني. تذكر المسطره دي.
ايوه.
بعدين عندك الواي اكسس والاكس اكسس. كويس؟ فعندك الاكس الواي هو الهوريزونتال صح؟ والاكس هو الفيرتيكال. طيب لو عملت السكيل بتاعك
الاكس الهوريزونتال والواي الفيرتيكال.
الواي الفيرتيكال. طيب في الواي لو عملت مثلا السكيل بتاعك عملته 5 5 5 كويس؟ واخر حاجه وصلت مثلا 60 في الورقه بتاعتك.
ايوه.
يلا لكن عندك فاليو اللي هي مثلا 100. ال 60 دي ما حتشيل لك بالسكيل بتاعك ده صح؟
ايوه.
انت حتكون خدتها في ترابيزه مش كده؟ الا بعد ده الشخبط في الترابيزه فوق هناك، لكن الورقه ما حتشيل لك.
ده تتكلم عن الماكسيمم فريكونسي بتاعت الماشين ولا شنو؟
ايوه الماكسيمم فريكونسي، الماكسيمم فلو فيلوسيتي. كويس؟
الماكسيمم فلو
السكيل بتاعك ده هنا ما شايله لك، حتمشي وين؟ حتمشي في الصفحه، حتمشي يا تراجع بتحت يا تمشي الصفحه لفوق.
ايوه.
عشان كده بتلقى البيك سيستوليك فلو فيلوسيتي مقطوعه. ده الاليازنج. انت عشان تجيب البيك دي بتعمل شنو؟ يا انكريز السكيل بتاعك، يعني مثلا بدل 5 تعمل 20 عشان ورقتك تزيد، مش كده؟ هاي تعمل لها كده او تزيد او تنقص الفلو فيلوسيتي. عشان ده الاليازنج اللي هي الصفحه بتاعتك اللي هو بتاعت السبيكترم ما شارت لك بس اكثر من كده، هي طلعت لك برا الجراف بتاعك.
طيب سؤال، ده regarding الماشين، ما ممكن تكون الفيلوسيتي بتاعت الهيمودايناميك اوف ذا فيسل itself هي exceeding الماشينز؟ ما حاجه يعني ما حاجه تكنيكال؟
ممكن هاي يكون very high flow velocity،
يكون very high velocity
above the setting بتاعك. هاي
يلا خلاني انا افكر في الشنط ارتيريوفينوس الشنط.
ايوه
انها
بالضبط
يكون
كده.
فيها هاي فيلوسيتي لانها ارتيريوفينوس الشنط، الزو انا ما شايفه يعني vessels ولا clumping of multiple vessels. I have seen a single vessels but this is definitely for the breast is abnormal.
صحيح. ونحن دي اكثر حاجه بنشوفها في الارتيريوفينوس فيستولا بتاعت الدياليسيس، يبدا تدينا فيري هاي فلو فيلوسيتي، بنشوفها الكلر دي. لو الفيستولا جيده بنشوف اول حاجه الجرين كلر دي قبل ما ناخد المقاسات بتاعت الفلو فيلوسيتي. بين ما اشوف الجرين كلر ده والله بنفرح جدا جدا صراحه، بالذات في دي معناها فانكشن فيستولا. لكن من ما نلقى الجرين كلر ده بعد
So,
ذاك نشوف مقاسها.
so you can take the findings of the يعني iatrogenic fistula of the renal dialysis
Yes,
and
yes,
apply
yes.
these lesions.
Yes,
So
yes,
my suggestion is not in the tract.
yes, you are right.
Is not way. Huh?
اوكي.
Okay.
طيب
Okay.
ده أنا من الحاجات اللي كنت عايز اعلق عليها في الطوق بتاعك ده. انا I'm going to quit، لكن عندي تعليقات بسيطه وانت ممكن بعد ذاك تواصل. كل السمري بتاع شايف بتاع بالنسبه للكلر دوبلر في الفلو اللي هو جاست انك في يعني انت ما شاء الله تكلمتي بطريقه يعني مبسطه، اقصد مفصله جدا عن النيو فاسكولاريتي. فاي زول اللي يحضر الطوق بتاعك ده بيعرف ثاني النيو فاسكولار شكله كيف. النيو فاسكولار يعني تيومر فاسكولار، مش النيو يعني نيو ما جديد، نيو NEO. فالنيو فاسكولار هي اتكلمت عنها بطريقه مفصله جدا وده كلام جميل. والنورمال فاسكولار، النورمال فاسكولار فلو اللي هو النورمال فاسلز والنيو فاسكولار اتكلمت عنهم بالتفصيل كويس جدا. ويزول اللي حضر كلامي ده المفروض ثاني بعد يكون عرف النيو فاسكولار من النيو فاسكولار. دي واحده. لكن لو رجعت لي للسلايد، اول سلايد ولا ثاني سلايد الاولى ديك، بس عايز اعلق شويه تعليق على الايديما، البريست ايديما.
Yes. حاضر.
معلش يعني.
لا you are welcome يا boss. You are welcome.
بس انا لانه بعد كده حاطلع لانه
Is your right.
الواحد ذاته والله يشفق عليك من كلامك الكثير ده وكل لسانك وجعك ذاته.
لا ابدا انا ذاتي حصل لي واكمل لهم. فضلت حاجات بسيطه في التوينكلينج ارتيفاكتس والحاجات اللي في دي بس. فضل كثير بالنسبه للاسم شنو ده. دايرين نتكلم عن الإديمة مش كده؟
هاي الإديمة فوق، ما هنا، ما في الكلام قبل ما تيجي لك.
أي ما هذه جيت للإديمة يا تو داير يا تسلايد في الإديمة.
ايوه.
البوست راديشن.
لا الإديمة ايوه خليك اجي في لي في ايدي
ايوه دي اليونيلاترال هارت اسمه شنو ده كارديك إديمة in the heart failure.
ايوه. طيب هنا لو تلاحظ انه الفات لوبيولز في الإديمة هنا بقت مور هايبريكوت.
يس
صح؟
يس يو ار رايت.
طيب الان بتوين دي هي الفلويد.
يس
الان بتوين الهايبوكويك ده الفلويد اللي هو الكونجستيون.
انترستيشال فلويد. ايوه
انترستيشال فلويد. يس.
يا
طيب الخلى الفات لوبيولز هنا تكون مور هايبريكويك زان نورمال زان نورمال بريست فات هنا، لانه ذا بريزنس اوف فلويد هنا عمل مور كومبريشن على الفات لوبيولز وبقت مور دنس. دي هنا عشان كده هنا بقت هايبريكويك، يعني في بريشر باي ذا فلويد، ذا بريزنس اوف فلويد. عشان كده بقى شنو هنا بقت هايبر دنس، بقت مور كوندنس فات. الفات ذاته بقت هنا مور كوندنس. طيب المنظر ده انا دائما بقول يعني شنو بيسهل عليه الدايجنوزيس انه دي ايديما ولا لا. كويس. بشبهها لما تمشي على البحر وتلقى البحر لما المويه يحصل الفيضان ذاك والمويه تنزل. كويس. الارضيه بتاعت الجروف بتكون مشققه كده. انا بسميها طين البحر دي، طين البحر الناشف.
والله شفتها يا بص، والله شفتها. كلامك يعني سبحان الله تشبيه بليغ جدا. يو ار رايت.
فدي بيقول دي الحاجه الوحيده من فروم ماي اكسبيرينس دي اللي بيسهل عليها انه ذا بريزنس اوف ديما، سواء كانت هنا في البريست او كانت في يعني مثلا
في الاذر
في الاذر بارتس. يس كان في اللور ليمس ولا في ماسلز. ايوه فاني وير السبكيوتينس ايديما بالمناسبه بتكون بالشكل زي ده.
يس
ده في الالتراساوند، ما في الالتراساوند، ما في الاشياء الثانيه.
Yeah.
الشيء الثاني قبل انت برضه ذكرتي انه قلتي اليونيلاترال ايديما in a cardiac patient. فدي this is most likely بتكون شنو dependent edema لما يكون راقد على سايد واحد
Yeah.
This is very very important. يعني عشان كده انتوا كلينيكال راديولوجيست كويس. فانت دائما خلي عندك شنو؟ كلينيكال داتا.
Clinical sense.
ايوه كلينيكال سينس انه ليه
مم.
الحكايه دي بقت مثلا يونيلاترال، ليه ما بقت بايلاترال مع انها كاردياك يعني. فهي لانها ديبندنت ديما بالذات. مثلا انت لو عينت للكاردياك بيشن لو كان مثلا لاين اون هيز باك بتلقى عنده ساكنه الهديمه
Yes.
برضه. ايوه في نفس اللي هي في الديبندنت
في
بارتس.
السي تي
اذا
برضه،
كان
في السي تي زي ما انت قلت، في السي تي مرات البيشنت
مم.
تلقى asymmetric edema one side more than the other.
يس يس
في الترانك ولا في السيكرم posterior ولا
يس يس
على حسب
يس
الديبندنت
ايوه.
edema. يلا
ف
عشان كده هنا يا
مم.
بوس قلت لهم انه يعني جبت سيره انه انا عندي couple of cases لانه هم they mention in literature a rare case and I brought this case from literature وهم they mention that it is a rare case. يلا انا ذكرت انه انا في البراكتس بتاعي عندي couple of cases بس انا ما لاقي الكولكشن بتاعي، لكن عشان اوريهم انها it is not a rare يعني ما ضد literature لكن ما rare. يعني انا شفت كيسز كثيره لاقتني بتاعت كارديك فيلير وبتجيني بيونيلاترال بريس إديمة.
صحيح.
ف المفترض انه اسمه شنو ده نتاكد ناخد بعدين.
المفروض نكتب الكلام ده نحن برضه عشان نوري انه الحكايه دي از نوت ريال. الناس المفروض تكونسيدر ان ذا براكتس. فجست انه ارجعوا للكلينيكال يس just a question in the history. Are you lying on your left side or right side or كده يعني. بس الحكايه دي هنا كده وبعدين يس ونعمل لينك للبوستشر اوف ذا بيشنت مع البريزنس اوف edema of that side.
Yes. Thank you very much. طيب.
Okay. Have a nice day. Thank you.
طيب we discussed this case with Dr. Rayah and he agreed about my suggestion of being a high flow malformation, probably arteriovenous malformations. Okay, and let me show you the breast Doppler. Okay, look here. This is the Doppler on the breast, and as we mentioned earlier, the vessels, look for the vessels, how are small and compressible and slow flow. Generally, slow flow. Normal pattern in the breast are small vessels running throughout the breast. Okay, very slow flow with low flow velocities. Okay, low resistance pattern with high diastolic flow, as we mentioned, and low pulsatility signal of higher diastolic flow and shallow slope. Okay, and easy compressible. So that is why with gentle transducer you can compress the vessel. Yani expected while you are scanning you could not see any vessels with routine pressure. Okay, but if you turn on the color Doppler, raise your hand from the probe, okay, to avoid even yani gentle pressure. Leave it without any pressure so as you can check. But these vessels, even with pressure, it was not compressible because it was abnormal. Okay. The increased vascularity, as we mentioned, in malignancy, pregnancy, inflammation, infections, some benign, less likely or few fibroadenomas can be hypervascular, but the most benign hypervascular is papilloma. Okay, and other intraductal lesion and in fibrocystic disease or fibrocystic changes. Okay, so also Doppler can be used to evaluate for subtle echogenic microcalcifications. The microcalcifications can give what is called twinkle artifacts. This is a punctate group of microcalcification on tomosynthesis, electronic what we call it, the glass, electronic glasses, okay, to visualize the group. And here we can see the lesion, a small lesion like micro cluster microcyst or something with micro calcifications. These are hyperechoic foci. And as we mentioned earlier, the microcalcification not giving shadow in general. Though this one here can show minimal faint posterior shadowing. When turn on the color Doppler, you see, we can see these twinkle artifacts in these calcifications, and the other one doesn't show the twinkle but demonstrate the posterior shadowing. So what is twinkle artifact? It is this mixture of red and blue colors, okay, seen in associations with when the beam of ultrasound or colored coming over a granular surface, okay? So this result in rapid changing rapid change of color. So that is why giving a mixture of color. And this mixture of color either at behind or adjacent to the reflectors, okay? So the color, the signal, the Doppler signal behind the strong specular reflector like calcifications or metallic clips or something, can help in identifying these calcifications. And twinkling artifacts are more sensitive for detecting small stone than acoustic shadowing, okay? Here, this is what we have seen in the previous example, and this is another examples of this microcyst associated with calcification, demonstrate these twinkling artifacts, okay? And we have to be cautious not to mix this twinkling artifact with the color signals of Doppler or power Doppler, color Doppler or power Doppler, okay? This is here, this example, we have calcifications, but this is a color, a power, this color here is not a twinkling artifact. This is a real or a positive color shown in a power Doppler in a case of DCIS. We have to separate or to differentiate between the two. Okay, let us see these examples here. This is a mammogram demonstrates post-clip mammogram, okay? And here, using the convex transducer convex probe, demonstrate the twinkling artifacts better than the superficial probe, okay? And then when they decide that is the location, then they use the 9 transducer, 9 frequency transducer. And here you can see the twinkling even less smaller than what we have seen in the Jeeber convex probe, okay? And from here, from this twinkling artifact, the site suggestive of the marker seen in a grayscale. They remove the color box and just check that in. And here we can see, check in the grayscale, and here we can see the coil or the clip, the clips with posterior shadowing. And then it's confirmed in the post-surgical specimen. Okay, here another examples. We can see this is a clip on mammography, and they use it and they introduce a radioactive seed localizers. Okay, and here on ultrasound, they can be appreciated, causing this a lot of twinkling artifacts, and then remove the color and visualize it without color. Then they can localize where exactly the clip or the coil, and this is the specimen here confirmed that the coil is seen within. And even here, they use it intraoperatively. The same process performed for the intraoperative specimen and confirms that it contains the clips. Okay, here in the here in the 9 frequency transducer, and this is the in the convex transducer pre and post radioactive. It's just post coil, and this is this post coil, and this is post operative specimen. Okay, and so also spectral Doppler tracing can be obtained as a normal vascular waveform. Also twinkling artifacts can be appreciated in a case of epidermoid cyst. Okay, and can you see it here? This is not a true vascular color signal in a lesions. This is just twinkling artifacts. Okay, and to confirm this is not a Doppler shift, this is only twinkling artifacts, you can use the spectral Doppler over this area and can confirm it. Okay, so associated features include architectural distortion, echogenic ring, duct changes, skin retraction, skin thickening, and edema and vascularity. We have discussed it today. And the elastography assessment later is going to be discussed. Okay, what is the ACR descriptor of this vascularity? What is the ACR descriptor? What are the ACR descriptor of vascularity in general? The descriptors are are you following me?
Vascularity inside the mass, and
yes.
ring vascularity, and no vascularity.
Excellent. So what about this?
Is inside the mass, inside internal vascularity.
Yeah, intralesion vascularity. Excellent, well done. Yeah, this is intralesion vascularity. This is the case, it is a hyperechoic, if you have seen with internal vascularity in case of angiosarcoma. Okay, what are the associated features here?
Skin thickening and edema.
Yes, excellent. Edema, associated feature, mainly edema associated with the skin
retraction.
Skin retraction, yes. The arrow going to the skin retraction. Okay. Descriptors of this vascularity.
Inside the lesion. Intralesional.
Yes. And the grade. Can you tell me the grade of vascularity?
High grade.
It is hypervascularity, yes. The grade of vascularity, it is avascular, hypovascular, intermediate
and
vascularity, and high vascularity. This is high vascularity, high internal vascularity. Okay. طيب.
Is it new genesis or?
Yes. New angiogenesis. What is the grade of this vascularity? How you are going to grade this mass? The mass.
The mass type
The
oval
grade.
uh, 4A.
No, not the ACR. The grade of vascularity in relation to this mass.
Vascularity.
Mm.
It is outside.
No.
يعني, there's no no vascularity.
And yes, avascular. This mass is avascular. This is a vascular mass. Okay, this is in the adjacent tissue. This is a vascular mass. Okay. What is the ACR descriptor of this vascularity? And the grade of vascularity?
Internal and hypovascular.
Is it hypo?
Intermediate vascularity.
Intermediate vascularity. And we have both rim or peripheral and internal vascularity. This one is, and this area is rim, okay, at the wall. And these are internal vascularity. Both internal, when the majority internal, it is moderately. It is a highly suspicious because it is chaotic type. The lesion morphologically suspicious and the vascularity suspicious. Okay. What is this vascular sign? And what does it indicate? What is this vascular sign?
Interrupted.
This is
the arterial venous sign.
Yes, parallel artery venous parallel sign. Artery venous parallel or parallel artery and vein sign. Indicative benignity. This is the fibroadenoma. And another fibroadenoma, you see, with this sign. Okay. What is the associated feature here?
Edema.
Edema, excellent.
Mixed vascularity
vascularity, associated feature, vascularity effect, edema, and vascularity effect, and skin thickening. Also skin, though it is secondary to edema, but it is also considered as, yes. Okay, but it's considered as part of associated feature. What is the ACR descriptor of this vascularity?
No vascular. ما في دوبلر ذاته مختلط.
None. Absent. Yes, absent.
هنا بقول not assessed ولا
absent. هنا if they ask you about the vascularity, you will say absent. Absent, it can be avascular, it can be not assessed. But it is an absent. The ACR descriptor is absent. That is the descriptor. Then you will search, it might be cut, it might be very big box and cut in this image. It might be there, we don't know. So what is the BI-RAD assessment? No vascularity. No vascularity, this is avascular. What is the BI-RAD assessment?
BI-RAD 4.
Excellent, BI-RAD 4. What do you suggest What is inside the cyst? What do we call these lesions?
Solid component. This is solid component.
We call the lesion is
We don't know it.
descriptor.
The complex كله على بعضه complex cystic solid.
Complex cystic with solid masses. Okay. And what do you suggest? Could you suggest this to be a debris?
No, because
Doppler.
is
Yes.
the margin of the solid component
This is most
doesn't
likely solid.
tabulate it. Yeah,
Although
irregular.
although it doesn't show vascularity, but still we cannot exclude soft tissue. Not only we cannot exclude, we suggest to be this. Why we suggest to be this soft tissue?
Lobulated.
Yeah, it is microlobulated. The shape, it is taller than wide and microlobulated. And even here, there is interruption in the capsule. Where the soft tissue, there is interruption in the capsule. So it is even more suspicious. It will be BIRAT 4C and so forth, okay? So no vascularity. What is the ACR descriptor of this vascularity?
Intraductal.
The descriptor intraductal?
الماس.
intralesional.
الماس.
Three.
الماس.
Yeah, the ACR descriptor absent, rim, and intralesion.
Intralesion.
Yes, or internal vascularity. Either to say intralesion or internal vascularity or intramass vascularity, all the same. So this is intralesion vascularity. Signify that this is what is inside the duct is not sludge, is not in specific secretions. It is a soft tissue, either papilloma or papillary growth, papilloma or papillary carcinoma type. Sorry, no, it's supposed to be intralesion vascularity, sorry. Internal
vascularity.
Yes, mistakenly. Okay, it is internal vascularity, huh? What is the ACR descriptor of this vascularity?
Internal as well as rim.
Yes, hypervascularity, this is a grade. But the ACR descriptor of vascularity is internal vascularity or intramass vascularity. Like, what is the BIRAT assessment? Two?
4C. 4C.
4C, excellent. What is your differential diagnosis? What could it be? What could it be? Could it be a cancer?
Yes.
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 Could it be granulomatous mastitis?
ممكن. Yes.
Yes, ممكن possible.
Yes, and this case it was granulomatous mastitis. Okay, that is why we have to be broad thinking. It is not just a matter. That is why we label it as 4 rather than 4T rather than 5, because it can be inflammatory, it can be neoplastic. Okay, and this it was they are on biopsy, but we have to recommend biopsy. On biopsy, there was no malignancy. It was just a granulomatous mastitis. Okay, what are the type of Doppler studies in this image? Here, this one and this one. This is more or less the same, but this one, this and this.
اسمها
This one, what is this one first?
this
Color
is the
Doppler.
color Doppler.
Color Doppler.
Color Doppler, because we could appreciate two colors. Okay,
Two
so
color,
this
yes.
is color Doppler. And what about the other one?
This is
باور
Power Doppler.
Not power.
التكنيك اللي قلت عليها
We have seen microvascularity. So
مايكرو. أيوه.
this is
Enhanced.
microvascular technique. You see, this is microvasculature imaging, high definition microvasculature imaging, color Doppler and high definition. Can you see here? This is the same lesion. Look for the color Doppler. What does it show? And look the high definition microvascularity for the same lesion. Demonstrate what? Intensive. This is the new vascularity. Look for the new vascularity. How much? This is here. It can be, if you look for this, it can be fibroadenoma, complex fibroadenoma versus it can be neoplastic, it can be cancer, it can be papilloma. There is differential. It is by RAT4, and even there is marginal, you see. But after this, it is highly suspicious, and it was proven to be invasive cancer. This is mammary cancer, both invasive ductal and invasive lobular cancer. But here, this is obviously speculated. Though it is speculated, with this minimal peripheral vascularity, it can be sclerosing adenosis, complex sclerosing lesions, or it can be malignancy. Okay, but it is more suspicious, more highly suspicious than this one. Because of speculation and vascularity, it will be by RAT5. Because still by RAT5, there is less than 5% probability of being benign. It is not 100%. But because the lesions simulated by RAT5 are not of benign lesions simulated by RAT5 are not much, not high percentage. Okay, and look for the new vascularity. Okay, so this is also, but the vascularity here a little bit less than this one. Okay, and that was invasive ductal carcinoma. Okay, and even if you look here, you can see vascularity from the anterior. Posteriorly, no vascularity. Even here, there is no vascularity. Might be here fibrotic, this portion necrotic and fibrotic, and this portion still there is cellularity. I don't know, but just I'm trying to analyze the findings. And here, this is two example of benign. Although it is not morphologically typical benign, but as you know, sometimes there is overlap between the two, and it were fibroadenomas. Okay, but some new vascularity seen in this fibroadenoma, but if you compare the new vascularity in a benign and malignant, definitely there is no comparison, okay, regarding this new vascularity. It is much more and much more aggressive in a malignant rather than in a benign lesions. Okay, what is the vascularity descriptor here?
interlesion
internal
Penetrating.
Intralesion, yes, intralesion or intramass. Is it suspicious or benign?
suspicious
Excellent. Why it is suspicious?
feeding vessel or
Yes, it is feeding. It is large feeding vessel. It is intra without seeing a marginal capsular. It is only intra lesions. It is irregular. You see, it is not yani, harmonics. It is not homogeneous of uniform caliber. The caliber is irregular. This portion different from this, different from here, and different from here. And when you look for this, can you see here the speculations and the echogenic rent? Huh? So this is a case of invasive cancer in a 51-year-old woman. Gray scale demonstrate irregular hypoechoic mass with speculated margins, and the mass appear to have a taller than wider. Do you agree? Yes.
No. Taller?
Yes. Yes.
Rounded.
Yes. If sometimes, if you measure from here to here, it might equal here to here. Okay. So rounded, considered to be taller than wide. If I cannot see a circular or rounded mass, but it might be the anteroposterior and transverse are equal. Roughly, it seems to be unequal. Okay, so, and sometimes even they look for the most deepest portion of the mass and measure it. If we consider this portion, it can be considered to be an unparalleled orientation. And the Bowel Doppler demonstrate this linear or curvilinear penetrating vessel traversing the mass, intra-lesion mass, or intra-lesion vessels, I mean, feeding vessels. So in conclusion, the edema, vascularity, and elasticity are part of the associated features in ultrasound lexicons. Edema is indicated by increased echogenicity of the surrounding tissue and reticulations. The angular network of hypoechoic lines representing either dilated lymphatics or interstitial fluids. It can be perifocal or diffuse, can be unilateral or bilateral, it can be benign or malignant, okay? And as we mentioned, especially the diffuse edema, it's more commonly due to benign process systemic cause or inflammatory breast conditions. Regarding Doppler ultrasound, complementary to grayscale ultrasound, and light transducer pressure is necessary to avoid vessel occlusions. It is optional since demonstrates substantial benign malignant overlap that did not improve ultrasound specificity much. Current ultrasound lexicon recommends evaluation of lesion vascularity but it is not a mandatory. Currently, both color and Bowel Doppler ultrasound are complementary to the grayscale ultrasound imaging and Bowel Doppler, as we mentioned, is more sensitive than the color Doppler to low flow volume typical of breast lesions, and may improve sensitivity of detecting malignant lesions. Identify irregular, branching, central, or penetrating vascularity within a solid mass is suspicious of malignant neovascularity. Generally, benign lesion show peripheral weak vascularity. Parallel artery and vein describe a reliable feature predicted of benignity in solid mass. Evaluate cyst and complex cyst with a solid component. High-grade invasive cancer and metastatic nodes may appear anechoic. Useful in evaluating scars. Demonstration of internal flow label the cyst suspicious for biopsy, intraductal lesions, and lymph node. Thank you for attention, and I hope you benefit from this discussion. And if you have question, comment, or anything, you are welcome.
Thank you very much, Dr. Rabab, for this nice presentation. It's a very difficult topic. You present it in a very simple way, simplify the information. Thank you very much for your efforts.
Oh, thank you for your nice comment.
جزاك الله عنا خير الجزاء دكتور رباب، الله
Thank you
يكرمك.
دكتور رباب. يديك العافية،
وجزاكم
تسلمي. جزاك
وجزاكم
الله خيرا.
يلا
وجزاكم
شكرا شكرا دكتورة رباب، شكرا. نحصل المغرب حقنا.
أوكي.